So you'll be forever on our website, at least. You may go viral.
We wish.
Not to use in a non-medical way.
But try to project your voice so it gets captured on the microphone.
Oh, I get it. Okay. May we begin?
Yes.
Yes.
Okay, good evening, everybody, and welcome. I wanted to explain how this all came about. In June, and prior to that time, the Health and Human Services Committee was discussing how to proceed with our work. And we had had many successful panels on important topics. We wanted to see what we could do more. Okay. Oh, I'm Shelley Fine, and I'm co-moderator with Audrey Isaacs.
Hello.
For this night's panel discussion. And we decided that it was important to have something come out of it. Okay, some actionable follow-up. And we thought it might be in the form of supporting legislation. But we didn't feel we were the authorities around various topics. At that time, the most pressing issue was the possible repeal and replacement of Obamacare. And within that, everyone had a feeling that the most serious, among many serious issues, what was going to happen with Medicaid. And in discussion, we realized that although we had ideas about Medicaid based upon personal experience, knowledge, etc., that we really didn't understand it well enough and how it plays out in New York State. And so although we wanted to support it, we had to understand it better and understand how it operates, who it covers, what it covers, and how essential it is. And so we decided we put together a panel of people who are knowledgeable from the advocacy and legislative aspect, who are active in terms of institutional applications, and from parent and community point of view. So we have a variety of people here today on the panel to cover all of that. We also decided that we ought to do some research and provide some information. So in this packet that you all have, just want to go over a few things just to help you focus and to see what's in here, because as a person in education, I find if you hand out a packet, sometimes the packet goes into the envelope or whatever you're carrying and never looked at again. So after the first 2 pages, which are English and Spanish of our agenda, when it says, what is Medicaid? There's information about eligibility. Very important are the next 2 pages, which is a chart of what in New York State is covered and what's not covered. Then there's information on New York Medicaid and about the federal and state share of Medicaid spending, because it's from both. And then there's some articles that were in the New York Times about Trump's budget and its effect on Medicaid and healthcare. So this is what's in the packet. More important than the people we have here today, and I'm just going to ask them to just lift their hand and to identify themselves as I mention them. And then we'll begin with some questions which we've provided for them in advance, so we can really focus our panel discussion on what people have said they need to know. So first, Paul Freitag, the Executive Director of the Westside Federation for Senior and Supportive Housing. New York State Assembly Member Richard Gottfried, who's been the chair forever of the Assembly Committee on Health and involved with the issue in a great way. Janora Johnson, who is a member of our board, but also the parent of a child reliant on the federal benefits because of his developmental disabilities. Kimberly Libman, okay, who is Director of Prevention and Community Development at the New York Academy of Medicine, Institute for Urban Health, and the New York Academy of Medicine we've collaborated with in the past in terms of its age-friendly program. I sit on that commission now, but it all began here. And I think we were the first community board to meet with the New York Academy of Medicine on that. So we certainly welcome you. Margaret Buddington, Chair of the Family Support Committee of the Office of People with Developmental Disabilities, and Chair of the Manhattan Family Support Services Advisory Council. And last but not least, Jose Varela, Chief Financial Officer of the William F. Ryan Community Health Center, which is in our community and been serving our community for how many years?
50 years.
50 years this year. So we look forward to a wonderful panel tonight, and we have committee members. I'd like to have them introduce themselves before we continue.
I'm Catherine DeLazaro. I'm co-chair of Health of this committee.
I'm Robert Espier.
Sonia Garcia.
Amy Hyman.
Angie Rosenberg, co-chair.
Audrey Isaacs.
Okay, and I must mention, and of course, Janora,
Janora.
and Christian Cordova. And I have to say something because it's important for people to understand. This was a collaboration as co-moderators, but the bulk of the work was done by Audrey. The planning was done together, but a lot of work, which makes things happen. She took care of a lot of the details and made it happen. Was persistent, and as a co-chair in this way of this project, I appreciate and I recognize the major contribution from my co-moderator. So we're going to begin. Audrey?
Yes. The first 5 questions I'm addressing to Assemblymember Gottfried, and he can elaborate beyond the specifics of the questions. You've all got the questions in front of you, but I will just read them out. Who has been entitled to Medicaid in New York State? What governmental entities have funded Medicaid in New York State? What services have been provided by Medicaid in New York State? Has New York State enhanced basic federal Medicaid coverage? What will be the impact of anticipated federal legislation on federal funding for Medicaid and other programs providing health care for seniors and persons with low income and/or disabilities? Assembly member, please take it away.
I'll start. I don't know if it makes sense for each of us to try to go through all of those questions.
No, you're the only one.
Okay, well, I'll do my best. So who is entitled to Medicaid in New York? Short answer, more people and more categories of people than I think in any other state. And that's been true from the very start of the Medicaid program in New York. We cover people who are in an income eligible household, and that those income eligibility levels are in some of the material here. I have never tried to remember those numbers, but it's basically low and moderate income individuals, children, parents of dependent children, adults in New York, at least, regardless of whether they have children, and a substantial number of older New Yorkers who may be eligible for Medicare, but are also eligible for Medicaid, both to cover the gaps in their Medicare coverage, things like costs that aren't covered under Part D, deductibles and co under Medicare, and most particularly long-term care, such as nursing home or home health care, and the elderly and disabled make up probably about, I don't know, 20%, 25% of the Medicaid eligibility, but they account for about 70 or 80% of the Medicaid spending. Vast majority of people who are on Medicaid are children and non-elderly adults who are relatively healthy, like the rest of the population, and their medical costs are a lot lower than the elderly and disabled. And I say that because people often think of Medicaid as oh, that's a program of free healthcare for people on welfare. That is in fact only in terms of spending, that is a small part of the Medicaid program in New York. Who funds Medicaid? It is basically funded primarily by the state and federal governments because of a formula set back in 1965. We are discriminated against more so than any other state because the formula treats New York as if it is a wealthy state, which it is, but that formula sort of ignores the very substantial number of poor people we have. As a result, basically, the federal government reimburses New York State for roughly 50% of what we spend on Medicaid. There are some categories of Medicaid spending under which the federal government gives us as much as 90 or more % of the cost, particularly the expansion population under the Affordable Care Act. We, like other states, get a much heftier federal match. New York, from the start of the program, imposed what is called a local share of Medicaid, so that when the program began, we got 50 cents on every dollar from Washington, the state put up 25 cents, and we required the county, or in New York, the city of New York, to put up 25%. The reason for that historically is that back in the late 60s, New York City, through what became the Health and Hospitals Corporation, was paying for a lot of health care for poor people. And upstate legislators basically said, why should we be bailing out the city of New York? Upstate legislators tend not to like to do that. And so the so-called local share was created. After a number of years, upstate communities began to complain like bloody murder about the local share, as if it was something we were inflicting on upstate New York. They didn't like to be reminded that it was their idea in the first place, but we are gradually now phasing out the local share. I forget exactly what percentage of Medicaid spending it now is. It's probably in the neighborhood of about 10%, but we basically capped the local share while healthcare inflation expanded the cost of the program. So that's who funds the Medicaid program. What are the services that have been provided? Like the question of who is covered, New York State's Medicaid program covers more than any other state's Medicaid program, and always has. One example is that when the federal government in 1977, I guess it was, through the Hyde Amendment, said that Medicaid would no longer pay for abortion, New York State continues to pay for abortion. We pay for it with state-only dollars. We get no funding from the federal government for that. Probably the biggest difference between New York and other states is in the area of long-term care. We cover much more home health care in more circumstances and more extensively than I think any other state, which is a good thing. Although even with all of that, we are still far from adequately covering long-term care, which we can talk about a little later. But you know, I go to conferences with legislators from other states, and I describe what we do with long-term care, and I get looks like, "Wow, you know, can we merge? You know, what can we? How can we get that?" The answer, of course, is elect a few more Democrats in your state. Something we need to do here too. So we cover a variety of home care program, home health care programs, and other programs that we cover through what is called usually called a waiver from the federal government. The waiver is a circumstance under which the federal government will waive certain restrictions and regulations under the Medicaid program, if the state comes to them and says, we have another way of doing it, we think it will save the Medicaid program money, like if we pay for home care instead of nursing homes, et cetera. So A, let us do that, and B, let us keep some of the money that we will be saving the program. So the federal government, if we convince that we're going to save the federal government $1 billion, they may let us keep 500 million of it, which is very nice. And so a lot of the home care programs that we have in New York for both children and people with disabilities and adults we are able to do under waivers from the federal government. The fact that we get federal matching money now for covering childless adults, which we did from the start of the program at complete state expense. I guess about 20 years ago, we convinced the federal government, I guess it was part of adopting Medicaid managed care in New York. We convinced them that that would save enough money that they should now give us matching money for covering childless adults, which they do. Let's see.
A quick question. Could
Yeah.
you comment when you say who is eligible, aside from income, is there a legal residency requirement for Medicaid eligibility?
Virtually not. Maybe one of you can be more precise, but basically if you've been here for a matter of weeks, you are eligible. And it takes that long to apply anyway. So it
But
is.
what about, I mean, immigration status is really what my question
Oh,
is.
okay. New York, as a result of a state Court of Appeals decision for the last 20 or so years, has covered immigrants who are here lawfully, even if they have been here, I guess, not long enough to qualify for federal matching money, unless it's too long to qualify for federal match. Anyway, but they have to be legal immigrants. Immigrants who are not here lawfully, if they are under 19, they are covered under New York's Child Health Insurance Program, CHIP. If they are here, I mean, if they're here under DACA, we regard them as being here lawfully. If they are completely undocumented, my understanding, and correct me if I'm remembering this wrong, is that we do not cover them. Again, unless they're under 19, in which case any resident of New York is covered under CHIP. I mentioned Medicaid managed care, which is an important component of the Medicaid program. Over 90% of when Medicaid started, it was a program in which you enrolled and your doctor or your hospital sent a bill to Albany, Albany sent them a check. Starting a little over 20 years ago, we required, and it's now over 90% of the Medicaid population, to be getting their services through one or another managed care plans. And so for a garden variety Medicaid recipient, if you want to enroll in Medicaid, you also have to sign up with a Medicaid managed care plan. The state pays that plan a certain number of dollars per month for them covering you, and they then pay your doctor or your hospital, not Albany. And if you are getting certain categories of long-term care, if you're getting home health care for more than 120 days, you must get that through something called a managed long-term care plan, which is a Medicaid managed care plan specifically focused on long-term care. The whole concept of Medicaid managed care has pluses and minuses. If we get into this. I think in the home care part of things, I think it has been a harmful restriction, which needs to be remedied. So, impact of,
Oh, no, for enhanced basic federal.
okay. Well, as I said, we cover a lot of things that are not part of the federal basic package. Some are optional. For example, drugs, which is an optional benefit under Medicaid. We have covered prescription drugs, I think, from the start of the program. We cover populations that federal Medicaid doesn't necessarily cover, and some of our long-term services are not part of the basic package. There is something called the Essential Plan, what New York calls the Essential Plan, which under federal law is called the Basic Health Program, another name that doesn't tell you anything. That is a program under the Affordable Care Act, which only 2 states have taken advantage of, Minnesota and New York, under which the federal government provides a high degree of subsidy for if the state provides additional coverage to low and moderate income households who would be eligible for Medicaid, but for their immigration status. Interesting that they got that into the Affordable Care Act. Kind of amazing that they got that in, and of somewhat higher income levels as well. New York grabbed that because we were covering about 250,000 immigrants completely with state dollars that the federal government was not matching us for, but under the so-called Basic Health Plan, called the Essential Plan in New York, they do miraculously give us matching money for covering those folks, a lot of matching money. And advocacy groups, particularly the Community Service Society, figured out that New York would have a net profit of about $800 million a year if we adopted the Basic Health Program. And even the Republicans in the state Senate, not known for being poor people friendly or, God forbid, immigrant friendly, when they saw those numbers, even they couldn't restrain themselves, and so we enacted the Basic Health Program. And the state profits like $800 or $900 million a year. So the next question is, I think, what damage could we be facing from Washington? And the answer is any number of billions of dollars over the next several years, depending on what the federal government decides to do. If they eliminate the expansion of Medicaid under the Affordable Care Act, then there are, I think, like $3 or $4 billion a year that New York State would lose right off the bat. If they move to a so-called block grant program, no matter how you structure a block grant program, it's bad for whatever program you are putting under a block grant. Because the block grant is virtually never as big as the program that it replaced. And historically, block grants hardly, if ever, grow in dollar amount. And so you start out behind, and then you don't grow. In the Graham-Cassidy bill, which fortunately now appears to be dead, not only would they have been block granting Medicaid, but with a formula that would have taken an enormous amount of money away from New York because we had expanded Medicaid under the Affordable Care Act. Those of you who remember the early days of Saturday Night Live about how every night, every week on Weekend Update, they would report that Francisco Franco is still dead. You know, so far, repeal and replace is still dead, but, you know, tune in next week, we'll see. Should I stop there?
Yes.
Okay.
Can I have a question, please?
I can take questions now if you want.
Just one quick question.
Yeah. And then you had a question.
We
Yeah.
said that we capped the portion, the local portion to 10%, so where's that 15% coming from?
Oh, okay. The question was, we capped the growth of the local share, and it has now decreased within, you know, as a result of inflation as a share of the whole program. Where does the rest of it now come from? The answer is the state government. We are, I think, the only state, maybe there's one or two others, that ever imposed a local share. So we are now gradually joining the other 49 in phasing out the local share so that the state will be picking up the full state cost.
Yeah, going back to the eligibility question. Somebody, let's say, that comes from Puerto Rico now that got destituted because of the hurricane and comes here to live. How?
Yeah, people who come here from Puerto Rico are legally the same as people who come here from New Jersey. They are U.S. citizens. Every resident of Puerto Rico is a U.S. citizen from the day they're born, just like any of the rest of us. And if they migrate to Florida, as many have, or New York, they are legally the same as if they moved here from New Jersey.
Okay.
We're going to hold those questions.
Okay, we're going to have a chance for more questions.
We'll have more
It's really
chance.
more of
Okay.
a point.
Okay.
Regarding the issue, Assemblyman, about the immigrants and who takes care of the immigrants, illegal immigrants. If I'm not mistaken, HHC does. They won't get a plan, but they have a hospital plan that the hospital takes in. Without
qualified health centers. And also the federally qualified health centers.
Oh, okay.
Yeah,
And the federally, oh, okay.
people who have no health coverage and are poor, if they show up at the Health and Hospitals Corporation, or if they show up at the Ryan Health Center, and a variety of other places, I think the people at St. Luke's would tell you that they too would take care of them, and hope that someone reimburses them for it. But that's not a good way to be receiving your health care. You know, if I need to see a doctor, I just make an appointment. I don't have to wait till I'm ready to go to a hospital.
Okay. Just point out that we're not talking just theoretical issues here, that on October 1st, we could lose $2 million in New York State due to a delay in a cutoff of certain federal funds for hospital issues that were delayed from 2014 from Obamacare. So things maybe a minute. I'd like to go around to each of our panelists and ask how you, in your role, and the people you serve will be affected by these potential cuts. And why don't we start over here with Janura?
Hi, welcome everybody. Speaking to this mic, okay. I'm Nora Johnson. I have a son that's 35 with Down syndrome. I wrote something here, but the Assemblyman covered most of the things that I have to say. Jonathan is, like I said, 35-year-old with Down syndrome, and I thought I had everything covered when he was born. As I get older, I realize that there's a lot that he needs, and to have these cuts would be devastating to us. I may one day need some of the health plans too, because I'm getting older. Our children have disabilities that, you know, that they're not going to outgrow. There's no cure for it, so they definitely need these cuts. What can I say? I'm just feeling like really, you know, I'm good right now. I'm so happy to meet Margaret. You know, she's taught me so much, and I'm glad to hear so you can take over.
Okay. Margaret, please.
Okay, so this is, if you can hold the mic to your mouth.
This is my son, Mark. We live around the corner. Mark is, like you know, his son, Mark is 37 tomorrow. And thank you. He has intellectual disabilities, and as Assemblyman Godfrey was saying, we're one of the groups covered by Medicaid. Intellectual disabilities are what used to be called mental retardation, autism, cerebral palsy, somebody with epilepsy, and similar neurological conditions. They are not illnesses, they're conditions. There's no pill that you can take that gets you better, although you can remediate some of the conditions with therapies and so on. But they're lifelong. That's the definition of them, and that's one of the most dangerous features when you're talking about block grants. We're extremely expensive to serve because our disabilities are intense. Our services are different and broader. As Assemblyman Godfrey pointed out, we use up a good deal of the Medicaid spend, even though we're a small piece of the puzzle. The reason why is because our services are broader than most other services. For instance, my son lives in a residence. He has 24-hour staff. He can never be safely alone, ever. And he lives with 4 other people in his group home. And all of them are the same. And you can't cut down the staff without impinging on safety and well-being. So he needs that. He needs an adult day program. He's always going to need these things. And there are times when he needs one-on-one staff, and other people always need one-on-one staff. Other people with developmental disabilities, for instance, if they have behaviors that are challenging and they can't navigate the world just independently at all. Some need one-on-one all the time. Some need it sometimes. Some need a ratio of 1 person to 5 staff. There's a variety, and there's also a range of intensity of the disability, from mild all the way to profound, where you have somebody who's not able to speak, who's not able to control any part of his body, who can't walk, who can't plan anything. That's a person who's totally dependent on services that are paid for through Medicaid. 90% of our services are paid for by Medicaid. We're different from everybody else in that way. You know, the fact that we are staff intensive, we have a wide range of services that they go on for the whole life. It's not we have a chronic episode and then we get, we level out. We don't level out. We always have this level of need. When we age, when our children age, they develop maybe a need for additional staffing. That ups the cost some more. Oh, what I was going to say, Medicaid pays 90% of our costs. Compare that to the hospitals where they only pay 40% of the Medicaid revenue. And our services, our developmental disability services, have no other avenue to bring in revenue. I mean, fundraising is kind of meaningless when you're talking about such staff-intensive services. Most of the money that we get in, I think 75%, goes for staffing. That's what our services are. We also have new people entering the system every year, about 1,200 new people. And our high costs make us a really big target when there's the situation of a block grant. In the block grant, you have competition among all of the different worthy Medicaid populations. We're all going to be fighting it with each other for, just sustenance.
I have a question. You said that Medicaid pays 90%. Who or what pays the rest?
The state. We have some state-funded contracts that people who are not citizens can take advantage of as well. They're mostly services to support families at home. They're not residential services, and they're not adult day programs. They're kind of softer services. So the hospitals, for example, and I'm not casting any aspersions on any hospitals, but, you know, compared to us, they're relatively well off. They have a big pot of money that they can spend if there's a competition among the different Medicaid populations. And we really are in not good shape. The services, well, should I come back for other things?
Yes,
Or
yes,
should I?
there's opportunity to say.
Yes.
Okay, good.
Thank you. So I think I want to try and bridge between Margaret and Paul, and just to sort of build on this theme about home and community-based services. So this is a strong theme in some of the very concerning literature about, you know, what the federal cuts could mean. So I just want to emphasize that Medicaid is an entitlement program, and as an entitlement program, you know, the costs will continue to be incurred even if the money doesn't come from the federal government, because the state is required to provide health coverage in these certain categories. And within that requirement to provide health coverage, there are a core set of healthcare services that are required to be covered. We've seen a nice list of them in here. And the thing to remember is that home and community-based services are an entire category of services that sit outside of what is required. So as we potentially move into a block grant situation where costs will increase, there will be reductions, we presume ongoing reductions in what the federal government will provide. New York State is going to become ever more pressed to figure out where we can find savings within our Medicaid system. And so the first thing that would likely get cut or reduced would be the thing that is not actually required to be provided. And that's everything that falls into this home and community-based service category. So all of the very important services that Margaret has been describing. Exactly. And then I think, I imagine Paul has more to say on this topic, so I'm going to pass it off, but I just want to flag that as an entire category of services that are particularly at risk with the block grant scenario.
Right, so that really teed me up. So just to give a little background on WSFISH, WSFISH stands for the West Side Federation for Senior and Supportive Housing. We're a 40-year-old organization that provides housing for older adults in 25 buildings. We have about 2,000 apartments that we run in these buildings. And what's interesting for me about this panel is that, you know, I've spent the last several years talking a lot about the relationship between housing and healthcare. And what it's always been is how stable housing can be so beneficial to healthcare and how it can actually help you provide healthcare in a very cost-effective way. And so New York State's actually one of the few, maybe I don't want to say the only, but it's one of the few states in the country that has these very innovative programs that are actually looking to use Medicaid dollars to build housing, because once you have high Medicaid users stably housed, their Medicaid expenditure goes way down. And right now there's a lot of sort of study of this to show that it's actually a very good return on investment. So now I'm going to turn that on the head and also just talk about how important it is to us to keep people stably housed. They need medical services, and in particular, they need Medicaid. And what they really need are the types of services that Kimberly was just referring to. So, you know, if I was going to say what's the most important thing that the seniors living in our buildings need, you know, it's not some, you know, dramatic medical intervention. It's a home attendant. And, you know, the fact that Medicaid will pay for home attendants to come in and help our residents, you know, organize their lives, escort them to appointments, you know, help them prepare their menus for the week, you know, make it so that they can eat well. You know, this is literally the difference between them being stably housed or being homeless or having to go live in a nursing home. So in a way, it's not in any way to minimize what Margaret was saying, but in a way, for most of our residents, it's sort of the opposite, that they're not very intensive users, but we're this, you know, these sort of smaller day-to-day, you know, supports that they get through Medicaid. Were they to be taken away, the results would be catastrophic. You know, so it's it's the sort of thing, you need the whole thing. They get home attendant services, they get transportation to appointments, then they get coverage for the appointments. So let's suppose transportation gets cut. Well, at that point, they're not going to make it to their appointments. You know, so even though, or it's going to be so much more expensive to get them to their appointments, just, you know, all these little pieces actually add up to allowing people to remain very stably housed.
Could you please repeat the name of your organization again?
It's the full name is the West Side Federation for Senior and Supportive Housing. We go by WSFISH. WSFISH.
Am I stealing the paper? Oh, it is?
It's on the,
Oh,
it's
sorry.
on this. It's on our free.
Okay, okay. And could you just say briefly, what are the requirements for a senior citizen, whether they're in a senior housing, like your buildings, or in their own rental apartment, to get home care?
So I can speak to the people who are in our
Right.
in our buildings. So our buildings all have an income requirement in order to live within them, and and the income that you need to have to qualify to live in most of our buildings is such that you would also qualify for Medicaid.
Okay.
So almost 100% of our residents qualify for Medicaid.
Okay, thank you.
Can I just mention one thing? How many people here are familiar with holding?
All right. That's all right. You can
Yeah,
ask.
full income trust.
Yes,
I just-
necessary.
it's-
It's okay.
I
You can talk.
oversee the care of an elderly neighbor, and it's something I learned about recently, but for people who pass the asset test for Medicaid, but whose income is too high, such as Social Security, to qualify for Medicaid, you can sign up with a pooled income trust, and your excess income goes into that trust, and they use most of it, they do charge a fee to pay your expenses. And that doesn't, the money that goes into the trust doesn't count toward your Medicaid number. I'm not aware of that being available in other states, but it's a very valuable tool for people who don't have enough to pay their expenses, whose income isn't enough to pay their expenses. For instance, if they need home health aides or whatever, but whose income is too high to qualify for Medicaid.
Interesting.
Apropos of that, I did a lot of research on that for my own particular needs. It's called supplemental needs under the pool trust. And you pay an initial fee, plus you pay a monthly fee, and there are 3 different categories of lowering your income. If you lower it really low to something 900, I have all the numbers, you can get Medicaid, but before that you can get your Part B paid for, et cetera, et cetera. But I found out you have to prove you're disabled. And that is very difficult. For someone like myself who now is facing a penalty, there's XYZ reasons why. I had Medicaid for a while, and so you have to pay a penalty of 10% of every year, and it's for the rest of your life. So I would have to pay, in other words, it's about $130 odd now that's taken from your Social Security to get Part B. It would be double that, and I can't afford it. So I'm without Part B.
May I just say something? It could be that one of the things that we should advocate for is to have attorneys available to talk to people just like you and discuss whether there's a possibility for a trust that would meet your needs.
Well, I spoke
not
to
talking about
Medicare,
you-
wait. I spoke to Medicare Rights. I spoke to NILAG. I spoke to many organizations that have lots of information, including several elder lawyers who didn't even know about these trusts. So the way it is as of now is that you have to supplemental needs. You have to prove you're disabled, and seniors get special, But I wanted to ask Mr. Gottfried, since you're the head of the health committee, I was told there are 3 or 4 agencies upstate that you have to go through to prove that your disability reaches this requirement in order to have this trust apply, that you can use it. Do you know anything about it? And who are these agencies that this approval has to go through?
I don't know what the process is for applying for these trusts, and what the approval mechanism is. I know organizations that if someone wanted the information, I could refer them to the health law people at New York Legal Assistance Group that you mentioned is one of them. We passed a bill in the Assembly and Senate, which is awaiting action by the governor, that would require the health department to provide notice to people applying for Medicaid about these trusts and describing, how you go about applying for them. The bill says that they have to explain that in plain language, and I've said to a couple of people, I'm not sure that is humanly possible, but hopefully they'll try. It's a complicated process, and it would be good if it were simpler, and it would be even better, and I don't know if we'll get to this, if we enacted legislation. I've talked to this to Board 7 before about my single payer bill. If we enact a single payer bill that includes long-term care, an awful lot of this conversation would not have to take place.
Can I just add some insight to the woman's question, if you don't mind? I work for Independence Care System. It's a Medicaid managed long-term care plan. And I work for Independence Care System. It's a Medicaid managed long-term care plan. And we set up the pool trust, and all of our members who are frail, elderly, and people with physical disabilities are eligible for the pool trust. And to be eligible for managed long-term care, you have to be in need of support and activities of daily living for 120 days. Mm-hmm. So you don't necessarily have to have that disability tag on you, as long as you are eligible for managed long-term care in New York City.
Yeah, but what is managed? What does managed care mean?
Okay, I don't think we can solve the specific problem here, but I think there's a resource there.
Yeah, but managed care means you have to be probably in a facility.
Okay,
no.
There's a lot of information, different types of trusts that I'm familiar with, and again, you don't have to have the designation of disability. So we've moved a little closer to information, but I don't think we're going to get the whole picture solved tonight.
Do you think after this I could talk with you that you might have some answers for me?
Might.
Okay.
Okay, at least the leads.
Shelley, I missed the why of the penalties, so can you go back to that a minute and explain why you're paying penalties?
Me?
Yeah.
If you, when you start receiving Social Security, don't immediately have Part B, which you pay for, you have to pay a penalty. Now, I had Medicaid for 5 years, and I was told by every service that I used that I had straight Medicaid and I was fine. And my Social Security went up a little bit, and I got a notice saying Medicaid was canceled. And when I went to find out about Part B, I would have to pay a penalty for those 5 years. And now it's going to be 10 or 12 years, given my age.
Okay.
So that's what the penalty is about.
It's a complicated situation. So if you're okay, we'll move on.
Hi, everyone. So I am the Chief Financial Officer of the William F. Ryan Community Health Center, which has been serving the community for 50 years now. And what's important for us over the last year is that even prior to the attack on the Affordable Care Act, and I think Shelley mentioned this, we receive funding. Our funding streams are broad in nature. We get federal, state, city funds, and one of those funding sources is part of our 330 grant, which is part of the grants that you receive as a federally qualified health center. Up to 70% of that grant is what is going to potentially go away as of the end of this week, which is a significant impact to our organization. So I know that it's further down on the agenda, but one of the things that we've been doing as an organization and really pushing out to the community is the advocacy efforts that we can make. Now, we are in a community that we're fortunate to have state politicians as well as our Congress people, both on this House and the Senate, who support us. But it's important that we continue that advocacy and not let down, and make sure that even with today's success, that we stay on top of it and don't allow it to rear its head again. But for us, we receive grants from the federal government for a 340B program, for the 330 grant that I just mentioned, Medicaid block. And so when we're looking at this in aggregate. It's not really one funding source. It's a potential attack on many of our funding sources. And as we get each victory, we're trying to prepare ourselves for whatever changes might come down the pike, but we don't want to be reactionary and make rash decisions as well. And so it's a tumultuous environment, obviously, but we're being proactive about looking at our programs. Obviously, our programs are broader in nature in terms of providing primary care, mental health, and dental services to members of the community. And one of the things that was mentioned before, I just want to point out again, is that as a federally qualified health center, one of our mission is to, one of our objectives within our mission is to provide services to all, regardless of their ability to pay. And so what that has meant over the last few years is we have had a lot of patients toggling between being uninsured and then being on either the essential plans or the qualified health plans that resulted from the introduction of the Affordable Care Act. And so what we're concerned about is that those patients that have been engaged in care, and it hasn't been episodic acute care, but it has been care where they really have a primary care physician. We've been engaged in proactively working with them regarding their health care, that they then don't become disenrolled in these programs and once again be uninsured, and then we only see them in, it's hurtful from a quality perspective for them, but it's also potentially much more costly for the system in aggregate.
Do you want to ask a
Yeah, I
question?
have a question. What I hear from my experience and work that I've done over the years in community health centers.
Could you speak up, please? Sorry, we
From-
can't hear you.
From my experience in the work that I've done over the years with community health centers, FQHCs, as a trade association supporting all the work, we supported the 330 grants vigorously, very aggressively, and with the support of the Assemblyman for years. Just to get an idea of the numbers we're talking about, in the early 90s, what we're talking about, the 330 grant is based on efficiency. If you run a center and you can document that you're efficient and you have good outcomes and all of that, your federal grant is gauged to that performance level. So we're talking about between back then, $400,000 and $700,000 a year that you can count on, and that's money for the uninsured. Okay, so that when you say that the cut to the 330 program, so of course my antennas went up. So this is a threatened cut along with everything else that's threatening us, or this is something that you know is coming down the pipe. And then what are we talking about? What kind of percentage? And then again, since I tell you that we were talking about those numbers back in the early 90s, what are the numbers today of the losses that we're talking about?
So just in terms of clarification, what's called the fiscal cliff, which is what we're talking about regarding the 330 grant, this was up for renewal regardless of who was in the administration in 2017. So this was a two-year extension that was to expire, or is to expire rather, on September 30th, October 1st. And so the challenge is given the pressure that we're trying to put, and we're working closely with both our local state association, Chicanes, as well as our national association of community health centers called NAC, to really put pressure on government to provide these services throughout the rest of the year, and then to continue it in 2018 and going forward. And the 330 grant is based on your performance as a federally qualified health center. And one of the ways in which we get reviewed is through essentially an audit from HRSA that happens on on a 3-year basis. And as an organization, the Ryan Center had that audit done last year. We did exceedingly well, and so from that perspective, we're not at risk. We're at risk. Yeah, we're at risk because of the potential cut to the grant itself. For us, it is a significant grant that has grown tremendously over the years, and so we are concerned that those monies will no longer be there. We will have to make decisions about what that means. Once again, we're trying to be not rash in terms of any decisions that we make about the services that we render. We will be in this community for the next 50 years, so we're not concerned about anything like that. What we're trying to do is be strategic in terms of our growth in the neighborhood, given the population that we serve. We're still almost 60% Medicaid. Just to give you a sense, we're almost 50,000 patients throughout Manhattan. All of our sites are within the borough of Manhattan, and about 60%, even though we are in neighborhoods that are gentrifying, we're still about 60% in terms of the Medicaid patients.
If I can just remind the committee, in terms of Bob's question, that this summer you got, if I can just remind the committee that this summer you had gotten some information regarding NAC, the National Association of Community Health Centers, and Chicanes, the Community Health Centers of New York, which is really spearheading the advocacy work going on around the fiscal cliff. So if you haven't yet signed up on those websites, please do so. Thank you.
And could I just add to that? I chair the board of another FQHC, which has clinics in Manhattan and 3 other boroughs.
Can you name it, please?
Community Healthcare Network. The irony is the federally qualified community centers have always enjoyed strong bipartisan support, because they serve people in many very red states, in rural areas where there is a real lack of health services. So this has never been about politics. We don't provide abortions, very careful about that. I think if the Republicans ever woke up to the fact that we are treating undocumented people, that might be a different story. But it really strikes me as an issue of the Congress just being so focused on repeal and replace that they have neglected the business that they need to tend to, which is to renew this legislation, which they have done easily with overwhelming majorities for decades, ever since the Ryan Center has been around. And so it really is shame on Congress for ignoring fundamental day-to-day duties that they have. It shouldn't be political. It isn't political.
Okay.
Same with the extension of the enhanced funding for CHIP.
CHIP, yes, absolutely.
Okay, so what we're going to do at this point is we're going to ask the panelists to tell us what they suggest that we should advocate for, whether in terms of legislation or allocation of resources. And then we're going to the audience to basically, and the board members on the committee, to basically tell us whatever you'd like to say, whatever your concerns are in facing these potential cuts, or whatever it is you'd like to say that's pertinent.
And follow up after tonight, if there is legislation or advocacy that we can do, because we're just not the community board, we have a borough board, we have access to a broader community of people to give support to what you're doing, which is really serving the people in our community. So we appreciate any information about legislation, any information in ways we can be supportive in advocacy. Maybe you don't want us to be for some reason because you have a way to do it that's better if it's not out there. But whatever it is that we can do, we love to have information following up. Thank you.
Okay. Mr. Varela.
We're going to go in the opposite direction.
Is there anything you wish us to try to advocate for that would be of assistance to the Ryan Center?
One of the things I've learned through this this recent process is not to be complacent. And so you probably have a politician in New York State that supports federally qualified health centers the most in this room tonight. I thank him for that. Yes. And as an organization, we go to New York State on an annual basis in March. We go to Albany, we go to Washington, and you have this sense of, well, politicians in New York State, politicians in our district and our city are supportive. Do we really need to do that? And the answer is absolutely. You need to continue to advocate for the politicians in your district, regardless of whether you believe that they already have your support. That's one of the key things that I've learned over the last year is to continue that even if you've done it already, to just continue to voice your support for a particular legislation.
Can I just ask, Fern mentioned a website that you could sign up on. Can you just repeat that?
I'm going to follow up.
So the National Association of Community Health Centers and the community, which is NAC, NACHC.org, probably you'll find it. NACHC.org, probably some version. Okay, but if you put NAC in, it's going to come up. And the other one is CHCANY, is the Community Health Centers of New York State. And again, if you put in CHCNYS.org, you'll probably get it. If you just put in CHCNYS, you'll get there, and you're going to go to their advocacy webpage. Sometimes it's a little different. Unfortunately, while they're great in advocacy, they don't always have that as first up. So you have to search around a little bit, but it'll come up. And I'll send you the links again, or Jose will send you the links for it tomorrow.
I just want to make a general response to what Mr. Varela just said, which is, as you are advocating and you feel that we can be of assistance, please contact, whether you contact the board, you contact the chairs of this committee, or you contact the office, just let us know.
So I guess just one thing I have to say to support Jose is that WSFISH actually in the last couple of years has really embraced an idea that we really want to see how we can use our affordable housing in order to promote affordable healthcare within our communities. So one of our goals is actually to pursue a co-location strategy. And we're currently under construction with a very nice affordable senior housing project in the South Bronx. And in that project, we are partnering with Urban Health Incorporated, who will be coming in and doing an FQHC as part of our development. It'll be a 5,000 square foot medical health center, not just for our residents, not just for seniors, but for the whole community. And in addition to that, they actually have a pharmacy that's co-located within as well. And we are currently in pre-development of a project that will be here on the Upper West Side on West 108th Street. And our goal is to do the same thing there. We'll bring in an FQHC in order to really promote the ability for community members to have affordable health care along with affordable housing. So, this is something, I think that there are nice linkages between, different social goals that can really reinforce one another. With regard to advocacy, we're very hooked into all of the affordable housing, senior housing groups that have very much embraced any threats to Medicaid because of to what extent Medicaid is such an important element in keeping people stably housed. So we work, some organizations that we work with are Leading Age, Live on New York, the Supportive Housing Network of New York, and they will always let us know in terms of sort of when there are advocacy opportunities for Medicaid, particularly around housing. We have a staff person that we've dedicated to making sure that we're going to the websites, that we're sending off the letters, that we're doing all that sort of stuff. We actually have somebody who attends the meeting every week so that we're really kept on top of Medicaid reform. And the story that I'd like to tell is that we actually did a little bit of soul searching because we knew among our residents there was a huge amount of anxiety about what was going to happen to their healthcare. And so there was sort of this question of, to what extent do we actually encourage or facilitate our residents to, go to demonstrations, to be part of letter writing campaigns? To what extent, do we sort of tell them that this is an opportunity? And the debate that we had is this going to actually increase their anxiety, or will it have a beneficial effect? And we thought, well, there's no way to know this without actually trying it. So we actually, there was a demonstration that was going to be about saving Medicaid. And so we asked people to sign up if they wanted to go. It was entirely voluntary, and and help them go to this. And then afterwards, when they came back, we sort of said, well, how do you feel about that? Was that good? Was that bad? And overwhelmingly, they felt really empowered. They felt like they weren't victims, it wasn't helpless, that there were things that they could do in order to preserve their own health care. And so it was great, and it was really fantastic for their mental health. So.
Well, in terms of legislation to support, I'm tempted to say duh. There is the New York Health Act, my single payer bill, which we've talked about before, which in a few months will pass the Assembly for a fourth year in a row with about a 2-to-1 margin. In the state Senate, we have 31 co-sponsors on the bill. The magic of that number is that is one shy of a majority of the state Senate as co-sponsors of the bill. I know enough about Albany to know that even if we have 32 names on the bill, that doesn't mean it gets to the floor and passes, but it means we are a lot closer than we've ever been. Governor Cuomo the other day, complete surprise to me, he was on the Brian Lehrer show Monday morning and was asked about what he thought about the Bernie Sanders Medicare for All bill, and he said he supported it. And then Brian Lehrer, who has had me on his program talking about it a couple of times, said, well, there's this bill in the legislature, the New York Health Act. What do you think about that? And he said it's an exciting prospect, but he said, we have to look at what the costs and the savings might be. That's a lot more than I thought the governor would have said. So, keeping his thinking moving forward is important at the state level, and supporting the Medicare for All Act at the federal level, I think, is also important. And I think that helps shape the politics of Washington, as well as having feedback on New York politics. Just a few organizations to mention to keep in touch with. I think the Community Service Society of New York, which is over 100 years old, while we're talking about 40 years and 50 years. They have a terrific health policy operation, and I think keeping in touch with them and their website on what needs to be advocated for and how would be terrific. NILAG, the New York Legal Assistance Group, does superb work particularly on Medicaid issues at a very fine level of detail, depending on how detailed you want to get into it. Last thing I want to mention, Chicane's, there's one extra letter in its name. It is CHCA-NYS, because it is not the Community Health Centers of New York State, which would be a sensible name. It is the Community Health Care Association of New York State. So if you're looking them up, if you're Googling them, CHCA-NYS.
You've been around more than I have. What's that, John?
Thank you. So I would be excited to support single payer legislation in New York State. And I think to maybe move us a little off our main topic of Medicaid here, I would be remiss as a Director of Prevention and Community Development, not to mention that the proposed federal budget cuts, there are proposed cuts to lots of things that we would consider part of the broader determinants of health. So, cuts to nutrition programs, SNAP, WIC, cuts to education programs, cuts to affordable housing that would have really detrimental impacts here in New York City on NYCHA, which is already struggling. And so I would encourage folks, while Medicaid is super important, also to consider that the Medicaid, our healthcare spending is only going to grow if we don't take care of people before they get into the healthcare system, and to consider advocating on behalf of reducing or stopping federal cuts to lots of other areas.
I would like to point out one area of advocacy where we've had some success. For over 11 years, we've been trying to get pay raises for the hands-on people who provide services to people with developmental disabilities. And there was a campaign, I don't know if you've heard of it, you probably have, Be Fair to Direct Care. And finally, we got $55 million in the budget, which of course could go, you know, with the wind if things don't go right. That the purpose of it is to keep the salaries of these people who do really, really challenging work and sophisticated work requiring judgment and much training and ongoing training, to keep their salaries at least above the minimum wage level. You know, the minimum wage is coming up, and one of the unintended consequences is that people who were doing a little bit better before now are back at minimum wage, and so they're kind of lost ground. So we did get this money from the governor last time, and there will be a continuation of that campaign this year, and it will be also extended to the teachers in the schools, the special ed schools, not the Board of Ed schools,
right,
because they pay way more and they recruit from the non-public schools. They recruit the teachers from there, so it's going to be extended to them as well. That's our biggest advocacy effort. The consequences of not doing it are dire. What happens is people, the direct support, hands-on people, start leaving and looking for higher pay in other fields, and we're left with staff shortages, and it's extremely dangerous what could happen. And this is part of the danger of the Medicaid block grants too, is the salaries will be frozen, not worse. Agencies might have to combine in order to have enough staff to protect the people they're charged with protecting. And that means you'll have larger and larger congregate settings, and you'll be approaching, God forbid, you know, an institutional setting. That would be just, it would make people's lives not worth living anymore. All of this has to do with health safety, but also quality of life of people.
First, let me say, I think it's great that we got the governor to increase the pay for direct care workers. I have to argue with your last point about the institutional settings, because New York has been getting rid of its institutional settings. They don't exist. It's more expensive to build them again than would be possible. They'll put people in nursing homes, but the good ones, the really good intermediate care facilities, have all been removed, and they should have been improved instead of being taken away. It's part of the continuum of care, and they've destroyed that system in New York State.
Right.
As they are in so many other states.
You're absolutely right about that, that there aren't any more, well, there's one institution left in New York State, but nevertheless, I was using it sort of figuratively, meaning a larger setting where individual needs are not going to be addressed, where people are going to be more warehoused than not. Exactly. That's what I meant. Yes. But thank you for that additional clarification.
And we need to just keep in touch and keep educating ourselves about what's going on. Don't feel that you haven't covered. And hopefully we can keep in touch with the panel and put some things on our website that, you know, different things. And what I learned, I will definitely bring back to the board. Because I have a family of advocates that's wonderful. So, you know, you don't know what happens unless you're there. So,
where's the advocate? I just want to ask Janora where the advocate is from. You say you have an advocate?
We have the Manhattan Community Council, Development Community Council, our families, you know, the different direct care and direct care.
Okay, so now we're going to the audience and the board members, and you can ask questions. So whose hand did I see? Manuel?
Why don't you?
Wait, so I come over and give you the microphone.
Why don't you come forward a little bit so everyone.
I'll need names for the minutes, please.
A former member of Community Board 7.
How you doing, everybody? Thank you so much, and I'm sorry I was late, so I may have missed at some point in the presentation. So my question is, I see the
I
data.
can't see you there. Why don't you come up to the table?
Okay.
We want you
Yeah,
on.
state your name
film.
so you can get it.
Manuel Casanova. I see the data that $34 billion are paid for from the federal government. What are we doing in order to face a potential, you want to call it a hurricane, where some of that money doesn't come anymore, whether because they do block grants, whether they do whatever they do. So eventually, I feel a little bit like people in Florida or in other parts of the Caribbean that, a hurricane is coming, you got to prepare. It doesn't hit you. We're only, 8 months into the Trump period? So we still have like another 4 years, hopefully not, but we still have another 4 years to deal with. So what are we doing as a state? Are we saying, hey, we're going to put this money away, or I don't know what, so just in case if that happens, you have that money set aside and say, this is what we're doing. Maybe the single payer plan helps to make that better, but what are we doing in terms of putting money away for that hopefully never come day of a hurricane of that magnitude?
Which panelist are you asking?
Oh, it's the assembly.
How we're lucky.
Yeah, well, first of all, we don't have money to put away. Any money that comes into the state treasury, the legislature appropriates. At the end of every fiscal year, if we miraculously are spending a little less on a program, or if tax revenue is a little more than we anticipated, it does go into a what is commonly called a rainy day fund. And yeah, we're going to be having rainy days, but that's not anywhere near enough to get us through the kinds of cuts in Medicaid and nutrition and housing and education and everything else that we're going to have to anticipate. So there are two things we can do. One is raise taxes. I am blessed with one of the only legislative districts probably in America where you can campaign for raising taxes and people give you a standing ovation. Even though I represent one of the 10 wealthiest assembly districts in the state. So one is raising taxes, the other is cutting. In the New York State budget, healthcare, meaning Medicaid, and elementary and secondary education is about 80% of the state budget. And so there's not much else to cut. We could eliminate the Department of Agriculture and Markets, and the state controller would hardly notice it. I assume that there are people in the division of the budget, somewhere in the basement of the state capitol, and some people at the health department who are, and probably have been for some time, looking over proposals for how to cut the Medicaid program. Hopefully what they're looking for is how to cut the Medicaid program in ways that will do the least damage. I expect some of those proposals will see the light of day. My job will be to fight against them tooth and nail. We've been through the Medicaid cut fights in this state in practically every budget going back to 1990 when we first started doing Medicaid cuts. That's what we're going to be facing. Now, I keep saying that the single payer bill, because I believe it would save an enormous amount of money, primarily in administrative costs, is one of the few things we can do that would free up money to fill some of the holes that Washington is bound to create in healthcare. But getting that enacted is an uphill fight, I would certainly acknowledge. And even if it became law tomorrow, it's probably a 2 or 3 year process to implement. That doesn't mean we shouldn't start, but it's not going to when it might produce benefit would be somewhere down the road. So raising taxes and cutting school aid and healthcare are the, parade of horribles we have in front of us.
Next questioner, please.
By the way, Governor Cuomo said there may be a need for a special session of the state legislature to deal with these cuts.
So my name is James Gibaldi. I'm actually from the mayor's office.
Gibaldi?
Gibaldi, G. And I'm from Thrive NYC, which is the new mental health roadmap that the city has laid out, 54 initiatives. Just want to let you know I'm here, and I have information if anybody needs it. I know it's not directly Medicaid related, but like I think the panel has discussed, all these things overlap. We've worked with many people that have been dealing with DACA, stressing out about that. Now we have people stressing out about Medicaid. So I think all these issues overlap, and I think that, if anyone wants to talk afterwards, just come see me. I'd love to collaborate.
Thank you.
The card.
The crisis of the safety net hospital, I'm Elizabeth Kellner. Crisis of the safety net hospitals in New York City is dire. I know we've been talking about primary care, community-based primary care, and preventive health care. The mayor just announced a new head of H&H, Health and Hospitals Corporation, but their budget deficit is in excess of $1 billion. They're trying to expand primary care. If there were Medicaid cuts, New York City's safety net hospitals, as well as safety net hospitals all over the country, would collapse. And so I don't know if anybody has anything. And the other thing I wanted to comment on is the governor's initiative on Medicaid reform and the shift to value-based payments. We have been in a model forever, time immemorial, of fee-for-service, whether you're a high-priced Park Avenue specialist or you're the pediatrician at Bryan Community Health Center. You see a patient, you bill, you get paid. Medicaid reform, which was something Governor Cuomo initiated along with the big task force over the past couple of years, is transforming that reimbursement system so that you will get paid for the outcomes of your patients. And that is another great uncertainty in healthcare funding that has nothing to do with Washington, D.C. So I was wondering if Mr. Varela could say something about that.
So I won't answer the health and hospitals question, but I'll talk about the, and I meant to mention it. So the acronym is DSRIP. This is the program that's been in place, and we are in year 3 of that program now. And what it means to our organization anyway is, really redefining the way, in some cases, we're structured. And so we've put a lot of investment in our infrastructure, the way our care management teams are set up, the way our quality department has been strengthened, because the way that we engage a patient in care, the way that we work with our hospital partners, the way we work with all of the partners that are part of the way in which the patient engages care and improves their quality and their outcomes and reduces costs, is the way that we're going to get reimbursed in the future. So we're in this limbo period right now where we're still getting reimbursed for the volume that we provide. And so when a patient comes in, a service is rendered, we bill for that particular visit. We get reimbursed based on what's called our PPS rate, which is a rate that all federally qualified health centers get. We're in this position where we're in both worlds right now. And what we've done as an organization is really put a lot of resources into being prepared to deal with this new world. And so that's another, it's not a resource drain because we're putting our resources where they need to be, but it's also potentially challenging if some of the funding streams that we talked about are going to be cut.
Thank you. Mr. Varela, it's a pleasure to meet you because when I was on Medicaid, I used Ryan's Center on 97th Street a lot. Got great eye exams, women's care, teeth cleaning, etc. But I've been told that now, in my condition situation, it would be $80 a visit. So I haven't been in years, and fortunately so far I've been okay, but I'm getting older. I just want to know, for someone in my situation, does the Ryan Center have anything to offer in reducing that cost per visit?
So as a federally qualified health center, we are mandated to institute what's called a sliding fee scale. And that fee scale is based on really two criteria. One is your family size and the other is your income. And so that policy is in place for everyone, regardless of your insurance status. And so I think that there's an assumption that it was in place for the uninsured only, and that's not the case. It's really based on your income and family size. And so we get any patient that comes in for any visit should be evaluated based on that sliding fee scale. And so we have put together what we feel is, we haven't really changed those numbers. We actually changed them, lower them over the last year. And so we think that the monies that we get, if we collect them from patients, really is a real fraction of the total cost of the care. But we do have, we're mandated to have that in place.
So the answer is no.
Well,
It's not right, it's all community health centers. The board of directors actually has to approve the sliding fee scale. It's the federal regulations to get the money.
Any other questions? Anybody have any questions?
Can I just ask one more question of Mr. Godfrey, please? If you get a single payer, will it affect seniors under Medicare and Medicaid? Will a single payer affect us? And, you know, how will it affect us?
Yeah. It would affect you in several very positive ways. First of all the gaps that now exist in the Medicare program, deductibles and co-insurance, et cetera, would disappear because the New York Health Act would pay for the entire cost of healthcare without any, patient contribution. The Medicare program would essentially be folded into the New York Health Act. If we had more time, I could go through the variety of ways that might be doable, depending on how cooperative or not Washington wants to be. Similarly, the Medicaid program would be folded into the New York Health Act. We would have to keep track of which New York Health recipients are Medicaid eligible so that we can draw down the federal matching money, but you and your doctor in your hospital would not know the difference between a Medicaid recipient and, the wealthiest person in New York. That everybody would carry the same card. And the program also would cover long-term care. So the notion of if you need home care, you have to spend down your income or put your assets into a trust and all of that is out the window. Every New Yorker would be eligible. There would be clinical criteria as there are today, needing assistance with activities of daily living, etc. But there would be no economic test for Medicaid coverage for long-term care.
Are there any other questions?
Sounds good.
Let me try it without the mic, and then just once you leave the microphone. I'm not sure to whom to ask this, but we've heard around this table in previous meetings the phenomenon sometimes referred to as fair, reasonable, and non-discriminatory pricing, where the same procedure at the same hospital would vary sometimes wildly in reimbursement cost or price between an uninsured person, a person insured by the Mark Diller health plan, the person insured by a health plan you've actually heard of, and then Medicare. So I guess one of the questions I have is, where does Medicaid fit into that? And short of the single payer bill, what is the right way to approach that problem, especially with respect to vulnerable folks like folks who are poor and folks who are elderly, and sadly those who are both?
Generally speaking, the Medicaid program is the lowest level payer, whether it's for, physician office visits or hospitalization. The Medicaid's level of payments are higher than they used to be, but still not what they should be. And if you talk to most hospitals, I think you would hear from them that they are willing to accept the low level of Medicaid reimbursement because they regard that as, part of their charitable mission. The next rung on the ladder is Medicare payments, which are somewhat higher than Medicaid. And then in most cases, commercial health insurance pays at a higher level. I keep saying in most cases because, for example, St. Vincent's Hospital down in the Village in its last days, because insurance companies, when they looked at Manhattan and said to themselves, which hospitals do we need to have in our network? Let's pay them more so that they'll be in our network. When they looked at St. Vincent's, they said, we want St. Luke's, we want Mount Sinai, we don't really need St. Vincent's. And so part of the reason St. Vincent's went bankrupt is because commercial health plans, some of them were paying them less than Medicaid, which was striking as a statewide phenomenon. Hospitals have quote unquote charges that they will say they charge for a given procedure. Those are usually wildly fictitious. Unless you are, royalty from Saudi Arabia visiting New York, nobody pays those prices. It enables the hospital to say, oh, we're losing all this money on charity care, we need more money from the state. But somebody who comes in without insurance is going to get a higher bill than the hospital negotiated with an insurance company. In New York, hospitals are required to offer reduced prices to low and moderate income patients who do not have health coverage, and that is of some help.
Any other questions?
One more? But you have to get the.
I have a question. You go to a hospital, and I had to do it with my daughter a couple times. You go to the hospital, you go in there to take her, she broke her wrist, goes in there, does all this stuff. You in, everything's all right. You go and say, okay, what's my bill? And they're like, well, I'll send to you. I'm like, I had a little thing here that you bid me around the building. You knew where I was, you know where we were. Why can't you tell me what's the bill? One of the things I don't understand of the system, and maybe here in New York we can do something different, is I used to work for an airline. If you were at JP Morgan, you booked a flight, you got a discount, boom, there you go. It's embedded in the system. I don't understand that you go to a hospital and you come back out, you're done, and you don't know the exact amount. That zero transparency First of all, it is because 3 weeks later, you get a letter written in some Egyptian language that says, this is what you had. So first of all, you're not sure. And then you got to figure it out. Then you got to go and talk to the insurance. So all that extra work, it's just making the whole system not transparent. And I can assume that there is also adding cost that we could use those resources somewhere else. Will we ever get a system where we can, again, you go to a hospital, not something fun, you go around, you finish, you said, okay, your bill is $100, your insurance pays $70, you got to pay $30.
Under our current system, moving to that degree of simplicity and transparency is really difficult and a real uphill fight. Hospitals are very powerful institutions in New York, even more powerful when they are in partnership with their unions. And it's one of the only industries where labor and management come to Albany to lobby in lockstep together. They are very potent. And, you know, on top of that, you know, no two gallbladder procedures are the same. They all involve different levels of complication and different additional services that might be required. And so at the time you're checking out, the hospital may not have added up what it all comes to, but that's really a very small part of the problem. The bigger part of the problem is they have almost no regulation on what they do, other than when they're dealing with Medicaid, Medicare, and insurance companies.
Any other questions?
Well, we want to thank our outstanding panelists. Thank you, we hope to be able to follow up. We'll be in touch with you. We hope you'll be in touch with us, especially around advocacy for what you understand is essential and important in general and at specific times. And we look forward to that relationship. Thank you so much.
Let's just say our thanks to Shelley and especially to Audrey, who was responsible for this.